Thank you.
Yeah. Hi guys, what an honor to come and speak to you. I think that it's worth to mention that I've been on conferences around the world in several regards, and I think you guys are the warmest and most welcoming and most enthusiastic crowd I've seen for many, many years. So I'm honored to speak to you. So my whole thing was I wanted to do research in psychedelics. So I come from the pain field, and there's been a lot of focus since probably like Charles was onto since 2016, emerging thoughts on how we can use psychedelics, classic psychedelics, in pain. And so I wanted to write a big rant, because I figured I've spent some years in the States, so I figured once you go big. So I applied for 20 million kroners, did not get it, but I got an excellent score. But before that, I wanted to show, sort of in a big perspective in Norway, what does the population, what are their attitudes and thoughts about using psychedelics, classic psychedelics, as medicine? Because one of the fears when doing this research is that you sort of add only people who really, really love psychedelics to your study. So you want to have, when you're doing research, you want to have sort of an unbiased sample as much as you can. So what I did was I chose to go in an epidemiological fashion out in the public and look at what Norwegians thought about psilocybin and how we could sort of tease out their willingness to try it as a medicine. Because when I looked at the literature, there's actually a huge gap. Norway, what are we doing? We're hosting this conference, it's awesome. But when it comes to data, we're way behind our fellow Scandinavian countries, but also the States, of course. So relative to comparable countries, we have had a fairly strict drug policy. So I think that this type of research, delving into what people think about psilocybin in this case, and what people think about MDMA and what people think about ketamine is important, because when you ask the general population, not just the innenfor Ring 3 in Oslo, Grünerløkka is probably a place where you will find more positive attitudes towards psychedelics than you do in Finnmark. So I wanted to check this out. So in clinical trials, this is especially important. So if you're doing a clinical trial like I was proposing, you need an unbiased sample to sort of generalize the effects to a larger population. And this is also sort of a way to limit my risk, because I think that once you start your trial recruitment, if you have a lack of willing participants, you will soon find yourself in trouble, because you have to wait years and years to finish your trial. So, as I said, we wanted to assess the attitudes in a representative sample of Norwegians. Two important questions: have they tried it? And were they willing to try it in a medical setting? So our sample was drawn from a huge panel. So I'm a psychologist by training. So we always want to play some kind of trick. So I didn't market this as a questionnaire about psychedelics. I just marked it as a general questionnaire about, hi, how are you? I'm Henrik. I want to ask you some questions about your income, about your political interests, and stuff like that. And in that package, we put two essential questions about psilocybin that I showed you earlier. So we avoided sort of a pre-selection by doing this. So we avoided people who were overly negative to just reject the study, and we avoided people who were overly positive to search out the study. We got a total of 1,078 participants. So this is the beauty of doing it in this way, as Otto is speaking perhaps more of later. In epidemiology, you want a big pond so you can draw out the representative sample. So that's what we did. We drew out almost matching number of gender sorry, sex, not gender. I didn't ask about gender. Sex, male or female. We pulled from all around Norway with a focus on Østlandet, because that's where, or southeastern Norway, that's where the most people live. And we had a fairly representative age group. So there were more younger participants than older participants. What is really cool is we had a 91-year-old who answered, one guy. And surprisingly, he wasn't very positive to this. But yeah, that's a different story. So the most surprising to me was how many Norwegians actually have tried psilocybin. So that's 8%. What?
Sorry, like
Yeah.
you do not know if you try psilocybin.
Yeah, exactly. Yeah. That's what's, yeah, but it's only 2%, so it's not a big number. So more surprising to me was that 8% said that they had tried it, and that's similar, not that different from the States. So, for instance, Krebs and Johansen, the people who were elemental in starting Amosophy, they did a huge population study in the US, and they found around 13% had tried psilocybin. So 8% versus 13% is not, I thought the discrepancy would be much larger. But 90% hadn't. So we wanted to, if we're looking closer at the people who had tried psilocybin, what's their sort of characteristics? So I think the coolest thing about this is actually the bar on your far right, which is the political affiliation. I was absolutely certain that there would be a Green Party and a Socialist Left Party would dominate. But actually the Conservative Party is dominating. So the way this bar works is that it shows the percentages within the category that has answered yes, we wanted to try psilocybin. So as you can see, there's a fairly good age distribution. There's difference in education. So the largest group was those between university and high school. And the income was also fairly distributed, but my favorite finding is the political affiliation. So the Labour Party, who actually turned down the drug reform, is actually one of the most popular parties when it comes to having tried psilocybin. So that's interesting in and by itself. When we did some quick correlations, we saw that it's not very surprising. Being young, male, and single, and living in a city, that actually determines whether or not you have tried psilocybin. So no surprises there. So likewise, there's maybe the essence of what we wanted to check out was if you were offered psilocybin as treatment for any applicable disease. So we mentioned, for instance, that psilocybin can be beneficial if you suffer from addiction, if you suffer from depression, if you suffer from a range of where we had documentation more or less of diseases. And we said, given that you suffer from one of these diseases where psilocybin has evidence, how likely is it that you would agree to try it as a medicine assisted by medical professionals? And so this cake diagram, I illustrated that by the red line. It's basically 50-50. So the participants in this study, 50% said, or a little bit more than 50%, 53% said that we are willing to try this as a medicine. And the 47% were negative. They didn't want to really try it as a medicine. But I think that is very positive. 53% is a lot higher than I would have suspected. And again, you look at the different characteristics of people who said that they were willing to try it. It's again male-dominated. They're younger. They have actually, when it comes to willingness to try it, education pops up. Then it's more highly educated people who were willing to try it. Also, people with a median income in Norway were more likely to try it. And again, the Conservative Party really loves psilocybin. So they were also willing to try it to a large extent. So the correlation matrices, which is really simple, just showing, because when you have this type of data, you can't do very complex statistics. It's a snapshot of what the attitudes are then and there when they're asked. So you can sort of put it in very advanced statistical models, but it actually, to me, it clouds the data more than it proves it. So I just did some simple sort of seeing what explains what, and not surprisingly, it's the same factors popped in. And in addition, if you tried it before, you were, of course, very willing to try it also as a medicine. But our conclusions were positive. This I presented to the Research Council. This actually bodes well for doing trials on psilocybin in Norway. We will very likely be able to draw a representative sample. And we think that this is a useful tool to have when planning more larger clinical trials. So in line with this, the Pain Medicine Research Group and the Mind Body Lab, we've been planning this and applied. I've applied 4 times alongside people here in the room for funding when it comes to doing psilocybin for pain. And as many of you know, there are emerging trials the first ones were in UCLA, where they had they're looking at amputees, people who have phantom limb pain from amputation, which is thought to be a very centrally driven pain, meaning that the central nervous system, in terms of pain matrices and spinal cord driven mechanisms, explain why the phantom limb pain occurs. And there they want to try psilocybin because of a very famous former employee in their physics department who experienced an accident and got an amputation and got cured by psilocybin. So they have gotten, I think, maybe $30 million or something, a huge grant. No, 30 million NOK. Not dollars, $3 million, I think, to run this study. Likewise, Johns Hopkins is doing a study on pain. UCL is doing things on pain. I spoke briefly with Malin, who will speak later today. So there's a lot of people who are getting into this and understanding the role of psilocybin, especially in pain and in different pain diagnoses. So I'm a little bit disappointed that we haven't gotten a grant here in Norway. So I've spoken to a lot of you about this, and I think that there's becoming more and more support for, or there's more and more support is growing for this kind of study. So what I wanted to do was basically look, because as a pain researcher, so you can focus on the narrative and the story and the perspective of the patient, and attention is everything in pain. But there's also interesting differences. So I worked with patients at the pain clinic here in Oslo for more than 10 years. And there are marked differences in, for instance, people coming in with amputees or with gunshot wounds or with surgical wounds. There are differences in the way the phenomenology, the experience of pain is in patients, based on what is originally the cause of their pain. So if their pain is primary, meaning musculoskeletal, meaning like back pain, neck pain, fibromyalgia, that kind of stuff, there is a different conceptualization from the patient than if it's a nerve damage, like a gunshot wound or an amputation. So there are interesting mechanistic differences in these populations. I'm not saying that they're, in the end, very meaningful, but I think it's worth taking into consideration. So my proposal was that when you look at this, you look at what is centrally driven, meaning that it's a increase in efficacy in the nervous system communication of pain signals, such as chronic widespread pain or phantom limb pain. But then you have what's called peripheral neuropathic pain, and that's really a fancy word for a nerve damage in the periphery, meaning that it's in one of your dorsal root ganglions just think amputated hand. So you have stump pain in the area where the hand is amputated, but you also have phantom limb pain, meaning you have pain in the arm that does not exist. So these are two different mechanisms. This is represented in your somatosensory cortex as being there, but not being there. Do you follow what I mean? And then there's the stump pain, which is the pain related to the amputation. And this pain, for instance, if I block this pain with lidocaine, this goes away. But the phantom limb pain remains. So there's a lot of hypotheses that thinking that this pain is driven in part by the input from the stump, while the phantom limb pain can sort of exist as a phantom in the brain. So my whole idea was to design the study about regarding whether or not this matters for the efficacy of psilocybin, because we all know that psilocybin is proposed to give effects from the alteration of 5-HT serotonin receptors, and that it's supposedly disrupt functional neural networks. So my thought was, okay, but if it also helps on stump pain, then it has to be something more. Maybe it's what Charles precluded to earlier. Maybe it's the experience that is everything, after all. So I'm not trying to prove the neurologist right, that there is a peripheral and central type of pain. I'm actually trying to prove that it doesn't really matter, and the mechanism that started the pain doesn't really matter. So I'm still on your side, hopefully, in that regard. So I wanted to do this study, and it received very well, it got very well graded, but it didn't receive funding. When I wanted to look at psilocybin, I also always think that these types of experiences, drugs, potent psychedelics, need to be put in a context, which I know all of you agree upon. So I did a rewriting of the protocol from Yale, where they're looking at this in treatment-resistant depression, and they're looking at this in the form of acceptance and commitment therapy. So if you look at acceptance and commitment therapy, what does it do? It's a context behavioral scientific therapy. So that means that context in the large scale, meaning both internal and external context, determines the range of your behaviors and, in effect, also your actual behaviors. So if you look at what psilocybin does, it releases you from the ego, it creates new learning opportunities. I think that that's a very good fit with acceptance and commitment therapy. And I think it's a very good fit because acceptance and commitment therapy includes both ego depletion, meaning and rebuilding. It includes specific behavioral tasks that gives you, for instance, exposure, fear exposure and avoidance exposure. It includes a focus on what matters most in your life. So I think it fits very nicely. And I agree with the Yale group that it's a very good candidate to do research in psilocybin. So I will try to continue to do this type of research and get funding, hopefully, at some point. So I will continue to apply for this. I think, in my mind, psilocybin should be the primary candidate, but I also think that MDMA is an excellent candidate for pain, that being more related to trauma and the results that you have on trauma. But I think both these two, one classical and one more emergent drugs, plus ketamine, is interesting for pain. So I think we have a bright future. Hopefully pain is one of the problems that we can get closer to solving by delving into psychedelic science. So that was what I had. It was a small thing, but I'm very enthusiastic, as you can hear, even though my English somewhat fails me. So if you want to contact me in any way and regard, please do. As I said, we have our own lab. So I'm the head alongside Professor Silje Remme. And we have many talented PhD students, among them Charles, who is soon done with his doctorate, but he will surely remain in our network, and we will try to get stuff going if we can. I'm very positive. I love you guys. Thank you.